Take care, everybody.
Amanda, you are up next. She is going to start us off with some weight inclusive care information. So I guess I should say finish us off.
Thanks, Jamie. Hi, everybody. Good morning. Yeah, I'm gonna talk to you about weight inclusive care today. So for those of you who don't know me, I'm Amanda Montgomery. I'm the manager of community health education at Heartland, but I'm also a registered dietitian, and so my favorite thing to talk about is food, and I have been talking to people about food all day long for many years. And so I want to kind of share some things with you today that I've kind of learned just in my experiences with patients. And I think just to kind of preface this, we live in a world that is very, that is very shameful, right? Especially when it comes to body size and diet, right? Like there's a lot of ideas of how we should and shouldn't look and ways that we should and shouldn't eat. And I think that comes a lot into the meetings that I have with patients, right? There's just a lot of shame around their bodies and what they eat. And so a lot of the work that I do is really kind of helping people connect back to, the foods that bring them joy and like meet their needs and feel right to them, but also, bringing self-compassion and reducing that shame in terms of their body size. And so I want to share some information with you all today kind of around what I've learned. That, both is kind of looking at the science, right? So we're going to look at some of the science about intentional weight loss and some of the harms that can cause, but also kind of how to take a weight neutral approach when we're talking to patients and really affirm their lived experiences. So I'm going to put my, share my screen with you all, and I'm going to try to run through this. I definitely plan for 30 minutes, and I'm not very good at being concise, so I'm going to try to be as fast as possible today. So bear with me. Oh, wait, how do you? Okay. Can you guys see this?
Yes.
Yes. Okay. Cool. And I just want to give a content warning too for what we're going to talk about. I am going to use the term obesity. I don't ever actually use that term when I talk to patients, but I will have it in here for the purpose of this presentation. We'll talk about fat phobia. We'll talk about dieting and eating disorders, and also some trauma and abuse. And all of those are really, really heavy topics. And so if you feel yourself, feeling anything coming up or anything like that, feel free to step out or take the time that you need. And I also just want to really quickly acknowledge my privileges and blind spots. In giving this presentation, I'm a white cis woman, and I live in a straight size body, which means that I don't experience fat phobia. And I am able-bodied, and I think those are really important things to note because people with disabilities, fat bodies, trans folks, and people of color are the people with bodies that are most oppressed in our society. And so because of my privilege, I don't experience those things. And I think that, it's really important to point that out, and that can be some blind spots in the presentation that I give. And I'm also college educated, and I think that's really important too. Like, I'm really grateful for the opportunity to be here and present to you all. But I think there's a lot of people with real lived experiences that don't get this opportunity that are so important to listen to. And I can go on a rant about this, but I think nutrition is also a super white science. It was founded by white people. It's researched by white people on mostly white people. And I think it's really important to kind of take a critical lens when we think about nutrition as well and what that really means for people. So that being said, we'll kind of get into it. And so I want to I'm not going to talk too much about this slide, but I really want to share that like in our society, like in the history of human life, right, 81% of human societies in history have had beauty ideals that favor larger people, right? Larger bodies have been associated with prosperity, while thinness was a signal of poverty and weakness, right? And I think that's really important to note because the idea of thinness as more valuable is something that's really recent in our society. And also just highlight that body diversity is natural. And I think we have this hyper awareness of obesity, right? In our obesity epidemic, right? Like all of those things that kind of have come up in medicine. But actually, body diversity is very natural, and there have been bigger bodies throughout all history, and that is not necessarily related to health at all. That's just, how some people are meant to carry their weight. And so I want to just make that clear. But actually, like, body size became this really hyper fixated thing because of eugenics and racism, right? So it was born out of colonization and race science, right? And it was used, we created a hierarchy of bodies that placed white bodies, especially white men, at the top, and used body size and eating habits to justify, civilization and evolution. And so that's kind of where this started, and that's kind of where it's been hyper analyzed in society, just as racism has been really perpetuated in our history. And an example of that is the BMI. And so the history of the BMI is that, it's created by a statistician named Adolf Quetelet in the 1830s. And he, it wasn't actually intended for medical use at all. The primary purpose was to find the proportions for the average human because he wanted to perfect the population. And so he only used data from white French and Scottish men because they had the perfect proportions for perfection, right? And so that's kind of where that equation came from. And, at the turn of the 20th century, life insurance companies started using this index. They just found it and started using it to set insurance premiums. So they kind of created the first charts and found a relationship between weight and mortality. But the sample that they used was only from the people that had life insurance policies with them, and all of their weights and heights were self-reported. So they created these charts that people kind of started to use, but the science behind them were very flawed. And Ansel Keys in the 1950s renamed the index to the BMI and determined it was the best tool to assess weight. And it's kind of been the main tool that we've used ever since then. But there's a lot of flaws with it. And I don't know, this has kind of been circulating a little bit recently, but, first of all, this equation was developed only based on white men. And it doesn't consider body composition, right? It doesn't take into account the differences in fat mass and bone density and frame size and muscle mass and all of those things, or health behaviors. And our weight naturally skews to the right, but when the index was changed, it was categorized along a normal curve. So people naturally hold weight that's a little bit heavier than where we set our BMI normal range category, but we don't really ever talk about that. And the BMI categories also are in fives for statistical convenience. There's not actually any clinical significance for where we set the BMI ranges. So I think those are important things to note just as we think about how we diagnose and categorize weight. And then a couple of other things, weight loss actually wasn't recommended medically before the 20th century. It just became incorporated because of this rise in the use of BMI and also just societal changing ideals of body size. So there were a lot of medical providers that were getting pressure from their own patients about weight loss and things like that. So it kind of just came to the forefront of our society. A couple of other things. The first bariatric surgery was performed by a doctor in Minnesota, and he coined the term morbid obesity to justify and grow his business because it sounds scary and would maybe make people more likely to get bariatric surgery. In the 1990s, the World Health Organization they changed all the BMI limits and lowered the normal range from 27.5 to 25, and that was based on information from an obesity task force that was created but is funded by pharmaceutical companies for weight loss drugs. So there was a lot of pressure to kind of make those ranges lower. And in 2013, which is really recent actually, the AMA, the American Medical Association, voted obesity a disease despite they had created a task force to kind of figure out if obesity should be a disease, and the task force actually determined it was premature to classify obesity as a disease because there's not characteristic signs and symptoms specifically for obesity, and there's a lack of evidence of any true causal relationships between obesity and morbidity and mortality. So I think those are just a couple important points when we think about the history of where body size comes from in medicine. And so when you think about, patients for obesity, right, or patients with obesity, the the recommended therapeutic intervention is weight loss, right? We always talk about weight loss. And those claims are based on just assumptions that weight loss is achievable and sustainable, and the assumption that weight loss is the key ingredient for improved health. And so we're going to talk about that a little bit and look at some of the research. So when you look at short-term weight loss data from studies, participants consistently lose an average of 5 to 10% of their baseline weight, but a lot of studies are not long-term. And so when you look at long-term data, regardless of initial weight loss, most weight is regained after 2 years, with up to 2/3 of dieters likely to regain more weight than they have lost on their diets. And this has been confirmed by a lot of meta-analyses, and it's supported by the National Institutes of Health back in 1992, and we still kind of moved this way with obesity guidelines. And it's also this chart on the side is from the Australian Clinical Practice Guidelines for Obesity, the ones that are currently being used, and it gives that statistic class A evidence that weight is regained. And the studies at the top of the chart, those are both really big weight loss studies. The one on the left has an N of like 48,000 people. And as you can see, right, like there's a big dip at like 6 months to a year, right, in terms of like maximal weight loss. But then that curve goes back up. And a lot of studies stop before that trend line evens out. And they just say there was a net loss, right, and that it was successful without following that trend line and actually seeing where that ends up. So I think that's really important. And there's a lot of errors in terms of weight loss studies. You know, a lot of them have really high attrition rates. A lot of people drop out and they don't report those data all the time. A lot of them have multiple interventions, right? So they're looking at weight loss and diet and exercise and mental health and all of these things all at the same time. And so you can't actually say for sure that like it's weight loss specifically that is causing the change in health outcomes, right? It could just be diet, right, or exercise, and there's no way to know because they don't change the controls to actually just look at weight loss specifically. And then a lot of them are really short in length, and there's a lot of errors in data analysis. So I want to talk about some of the physiological impacts of food restriction, right? And think about why that trend line might go back up, right? And so really like our bodies evolutionarily are resistant to change. We're good at gaining weight. I think our bodies are really efficient at storing energy. But we're really like, we're not good at losing weight, right? That's not what we're supposed to do. And I also want to note that like we have a set weight point that ranges 10 to 20 pounds. And I think in a society where we're hyper aware of any change in our body size, you know, a gain in 5 pounds might be really scary to somebody, right? To be like, oh my God, what's going on? You know, when that's actually very natural. And I think that's important to keep in mind. But on the side here is this is just a couple key players in you know, food metabolism and body size management. And so ghrelin is a hormone. It's your hunger hormone. Like when your stomach is growling, you release ghrelin. And that's it signals your body that you're hungry, right? You need glucose. And then on the other end of that, leptin is a fullness hormone, and insulin as well. You know, once you've kind of, you know, is secreted to meet the glucose needs, and also signals to your body that you've like met your glucose needs. So those are key players in kind of appetite control. And they're very, very good at regulating our body's needs. But when we listen to outside cues, so deciding like, oh, I need to lose weight, or, you know, whatever that is, when we listen to those outside cues, that system shuts down and our body can't hear those signals the same way. And so it increases our susceptibility to outside food cues, which is why somebody might be at the buffet and they just can't stop eating, right? Because you don't sense your fullness signals anymore. It's harder to kind of tell those things. And when we do that, right, like the system breaks down, and in response to that, ghrelin, your hunger hormone, increases and leptin decreases, right? So you get hungry more often and you're not full as fast. And so that is a way that your body is helping to actually increase your set weight point. And so there's often an increase in weight because your body is trying to protect itself from any future potential like famine, right, is what it kind of sees. There's also a lot of other things that happen that increase fat storage. carbohydrate cravings, when you lose weight, you reduce your muscle tissue more than your fat tissue, and so you're going to have a lower metabolism. And I won't go through that study just for time, but that was seen in the Biggest Loser competition. After 6 years follow-up, they had a really really large, even though they had gained back a lot of their weight, their resting metabolic rate and their leptin levels remained way lower than where they should have been after regaining weight. So that's just a physiological example. And thinking about food restriction, like, your body doesn't know that you're restricting, right? It thinks it's not like, oh, cool, you're on a diet, that's fine. Like, we got you, right? It thinks, oh no, you're keeping food from me, right? That's bad. And so that happens, and it's like a pendulum, right? Where you pull it to the side. And if you're dieting, if you're food insecure, but this also happens a lot with people in bigger bodies, right? A lot of the times they feel scared or ashamed to eat around like other people. And so they'll wait, right? And eat later. And so any type of restriction, your body responds by pulling that pendulum all the way to the other side, right? And so a lot of the times, as a response to that restriction, you'll get binge eating, overeating, and like rebellion. And then other impacts of food restriction, I'm not going to go through these too much, but a lot of them, when you're restricting food, some really big ones are just like low energy, hair loss, irregular periods, and increased hunger. And I think a lot of people get those things and they like don't know why. And those are like really big responses to food restriction. And then weight cycling is also a really big part of dieting, right? Because a lot of people are trying to lose weight. So they go on a diet and they lose weight, and then they regain the weight, and then they go on another diet and lose weight, and then they regain the weight, right? And so, weight cycling is actually not, it's like worse to just do weight cycling than it would be to just stay at whatever weight you were, even if you were in an overweight category, obese category. And it's associated with all-cause mortality from heart disease, risk of heart attack, stroke, and diabetes, and then high blood pressure, and also suppressed immune function. And this study was a huge study out of the UK. And then they tracked BMIs from 2004 to 2014 and found that that people that are in the quote unquote normal BMI range were way less likely to weight cycle than people in the heavier BMI categories. So like 51% of people in bigger bodies were weight cycling throughout those years versus only 20% of people in quote unquote normal range. And I think that's really important to think about too when we think about bigger the pressures that folks in bigger bodies might face when we talk to them about weight. Also, disordered eating and eating disorders are a really common part of this too. And those behaviors include fasting, chronic restrained eating, restricting major food groups. So maybe the keto diet or paleo diet or something like that, the Whole30, vomiting, laxatives, and binging. And so many people are on diets. Honestly, and dieting, that's a risk factor for disordered eating. And so a lot of people also have disordered eating, and it's also really high in trans folks, and it's rising in men. I think we think about, often like women that are watching their weight when, it's really high in a lot of other populations too. And in the US, children are 242 times more likely to have an eating disorder than type 2 diabetes. And a lot of the time, I think it's like 50% of children by the age of 9 have tried to restrict their food in some way, which is really scary to think about, that kids that young are thinking about those things. And also, disordered eating and eating disorder rates are actually higher in people of color, but they're often more underdiagnosed. And so this study on this side was from the National Eating Disorder Association. They quoted this, but they had providers that were looking at identical case studies, looking at disordered eating symptoms in white, Hispanic, and Black women, and only 44% of providers only identified 44% of the white women's eating behavior as problematic, which is really low in general. And I think that speaks to kind of the normalization of dieting and like restricted eating that we have, but also only identified 17% of Black women's eating behavior as problematic. So I think that's important to keep in mind. A lot of the times we just don't think, we don't think about the way that those symptoms might present in people of color, and especially with a really large population of white medical providers just in our society, right? Okay, I'm gonna try to go fast because I know it's almost 9:30. So if you can hang on for a couple more minutes, that would be great. Um, and so I just want to, talk about, I feel like we talk about diet related diseases all the time. And I want to say that, like, I'm not trying to say that like nutrition isn't important or exercise isn't important, right? I think like there's a lot of research that shows that diet and exercise and intuitive eating, which is listening to your kind of interoceptive awareness and internal signals, all have extreme health benefits for everyone, regardless of body size, right? And and so those are so important, right? Regardless of your weight, those are important initiatives to kind of to focus on with patients, right? But I think that we sometimes overcompensate for other things that are maybe happening in people's lives with diet and exercise, right? That's just a lot of the time what we tell people to do when it's really like that's not the root cause of what's going on. It's important to think about, but it's not always the root cause. And so other things that are correlated with disease rates and also, kind of the change in trends in weight in our society are dieting and weight cycling. Those are correlated with those trends, but also weight stigma and trauma. And so weight stigma is discrimination or stereotyping based on someone's weight. And it's reported at rates very similar to racism, and it is a type of threat. And these are just some examples. I'm not going to go through all of them, but please read through them because a lot of them are related to the medical profession. And it really is a threat, right? And so when you receive weight stigma, like somebody making a comment about your weight or feeling discriminated against based on your weight, that activates your stress response, right? So you're in this fight or flight mode, you have this increased cortisol, and that's happening all the time because we live in this society that's very stigmatizing to people in bigger bodies. And weight stigma is an independent risk factor for a bunch of things, right? High blood pressure, inflammation, stress markers, A1C, metabolic syndrome, depression. It also is, a risk for maladaptive eating behaviors and eating disorders and weight gain. And so I think that's important to think about too when we talk to patients about their body size, like what that could be triggering for them. And then, just literally like the morbid, like that term, like morbid literally means indicative of death and disease, and obesity means having eaten until fat. And I think, I don't know how many people think about that, but that's like that inherently is a harmful term. And the fact that we kind of throw that out at people, when our role, as healthcare providers, right, is to be is to improve health, right? And that's kind of the way that we're kind of naming people, I think, is really harmful. And the incidence of weight stigma has increased by 66%, with the rise in the public health campaign of ending the obesity epidemic. And healthcare is one of the biggest sources of weight stigma, right? And when people feel stigmatized, they're going to avoid healthcare, right? And so people in bigger bodies don't come because they don't want to be fat shamed, or they don't want to just be told they just need to lose weight, right? And there's, a lot of people, when they don't come, then they also don't get their preventative care, right? So they're not getting the screenings that maybe they should be getting or things like that, and which is really important. And they also, people in larger bodies reported rates 3 times higher than people with average BMIs, that they're denied appropriate medical care. And that can lead to misdiagnosis. But I think it's also important that we think about a lot of people in smaller bodies are also like things get unnoticed because we think that they're just fine when actually things could be going wrong. And so I think that's something to keep in mind. And then these are some comments that I've heard from HHC patients. And honestly, it's very rare that I talk to a patient that has a very healthy relationship with food. This is more of what I get all the time. And it's really sad. I think that this is kind of the environment that people feel, and you all might feel it too, because we all live in this system that kind of makes people feel bad about their body size or their shape or what they're eating all the time. And then in children too, weight-based bullying is one of the most frequent types of bullying experienced in schools. And a lot of the kids that are being bullied, it's associated with increased binge eating, and they cope with these feelings through avoidance of physical activity and increased eating, right? And so this is really big, and it also is happening really frequently by parents. So weight-based teasing by parents is associated with emotional eating and binge eating as well. And I think that's important. There's a lot of, I've seen parents too in my work with youth, that are telling kids you can't eat that, you need, you're too big already, right? Like making these comments to kids and restricting their weights is a really big thing that I think is important to keep a lookout for with children. Excuse me. And then trauma too. I'm not going to talk about this too much, but like the foundation of ACEs was really because they were trying to figure out what was happening with a dropout rate in their obesity clinic, right? Their weight loss clinic. And so actually most people with an eating disorder have a history of trauma, and many have also had PTSD. And I think this is important too, because food is really can be a coping mechanism to distance themselves from disturbing thoughts, but also to reduce their attractiveness, especially if someone's been sexually abused. And I think this is also extremely important to keep in mind when we talk to patients about their eating habits or their body size. Food might be a coping mechanism that is extremely safe and comforting to them. And so before we talk to them about weight loss or changing their habits, this is something that we need to think about first. And what is their relationship with food and what might this be doing for them? That doesn't mean that it's the best thing to help them cope, but it could be something that's incredibly safe. So, I think just in thinking about takeaways, your responsibility and my responsibility, right, is to first, harm. And so thinking about that, intentional weight loss often isn't sustainable and can lead to a lot of psychological and physical harm. And we really can't tell what people are going through until we ask them, right? Weight does not equal health. Body diversity is real, right? People just naturally sit at bigger weights without any indication of their health. And I think, just kind of remembering about trauma-informed care and really finding tools to help people cope with whatever food is helping them through. And I think also, right, again, kind of going back to this idea that bodies, we live in this culture that is focused on healthism, right? That food and your body size is a personal and moral responsibility. We're supposed to be working on it. And I think that really shifts the focus away from the fact that fat liberation and food access are social justice issues, right? These are larger systems of oppression that are impacting people. And I think, just telling people you just need to change your diet isn't necessarily getting at the root. And that doesn't mean nutrition's not important, but it's not necessarily getting at the root cause of a lot of these things. So thinking about what you should do, right? First, taking a weight neutral approach, right? So focus on evidence-based health interventions that don't include weight loss, right? And recommend the same evidence-based interventions for patients in larger bodies as you would for patients in smaller bodies. Don't use the term obesity, right? Use non-stigmatizing terms, right? So saying people in bigger bodies or people in larger bodies. You can also ask somebody too, what they prefer to be called. There's a lot of people that just want to be called fat in a non-stigmatizing way. They've just reclaimed that term. Ask the patient what their health goals are and prioritize those. A lot of patients in bigger bodies just come assuming you're going to tell them to lose weight when just take their goals seriously and prioritize what they're telling you they want for their bodies. Also, I think before you recommend anything, right, address food insecurity, financial stability, and then check their relationship with food, right? Check their history of weight cycling, look for disordered eating patterns, ask them about their relationship with food or their relationship with their body, right? Kind of get that information before you prescribe anything. Also, don't moralize foods. There's no good and bad foods, right? There's foods that do different things for us. But don't tell somebody you need to stop eating these things, right? That's just that kind of brings back that shame piece of they're a bad person or they're doing something wrong. And then with both eating and movement, right? Focus on things that meet them where they're at, right? Focus on eating for pleasure, for hunger and satiety and nutritional needs, not weight, right? And in I just want to plug the intuitive eating group that Srila and I do. Really is what this is, and it's really focusing more on finding joy and pleasure in eating and understanding what you need for yourself. Promoting mindful movement, focus on joy and connectedness, not weight loss, right? Helping people connect to movement that makes them feel good, because those are initiatives that they're research based, right? That their health improving, right? Mindful movement and nutrition. Helping patients kind of work through their emotions around food and finding self-compassion. And that can just be connecting them to like a BHC or a therapist somewhere, a counselor, helping them reduce their shame, maybe around their bodies or around eating. And then also exploring your own internalized fat phobia. I think this is really important, right? Are you afraid of gaining weight? Do you make assumptions about people based on their body size, right? Like, what are some things that you might do that maybe are fat phobia? And I want to give compassion, because I think we all live in a system, and my training in nutrition, and I'm sure medical training, didn't talk about this. And so I think giving yourself that compassion that this might be new for you is really important. But also being okay naming your privilege, right? If you live in a thinner body, you know, kind of be okay with that. And then system-wide changes, if we could just not use VMI as a measure of health. Not requiring patients to weigh themselves unless it's like a necessary, right? But even just asking them, do you want to be weighed, and giving them the option before we require them to be weighed. There's a lot of patients that just do not come to meeting or to appointments because they're afraid of stepping on that scale and knowing you're going to talk to them about that weight. And then last, equipping your facility with size-inclusive blood pressure cuffs, exam tables, chairs that don't have handles on the sides, right? Like, all of these things are things that we could be doing that kind of create a more affirming space for, I mean, all people, but also folks in bigger bodies, which is really, really important for their health. So that's it. These are some resources if you want to look at those. There's also a panel coming. I'm getting my master's in public health, and we're bringing this panel. So if you want to come to that, feel free. That's it. I'm going to stop sharing my screen. And I'm sure some people had to leave, so hopefully they'll look at the recording. But I really love to talk about this. I talk about this all the time. And so if you all have any questions or want to learn more, you know, the resources I put in the presentation are really good, but also you can reach out to me. I have so many, I don't know, I just love to have these conversations. So yeah, that's it. And also, I didn't say this earlier. I don't know if anyone asked any questions in the chat, but if you did, I will respond to them in email. I don't want to keep you all super late.
Thank you so much, Amanda. That was great. If it's possible for you to drop in your PowerPoint too to the chat, that would be awesome. Does anyone have any last comments for Amanda? Yeah.
Hi, this is Anuj. I just like that was great. Thank you, Amanda. And I will say that like in my integrated medicine consults, I just see this a lot where people come and I start uncovering their story, and there's a lot of body.
Oh no, you cut out. I don't know if you're still talking.
Oh, can you hear me?
Yes.
Okay, I've just had to do my own apologies to patients, given that I know that I've been guilty of fat shaming folks in their youth, and probably putting things and trauma in their own bodies as a physician. And now that I'm doing some integrated medicine consults, I'm seeing what harm that has done to adults. You know, we're like, oh, I went to the doctor when I was 8 and they told me I was fat, and ever since then, all of this stuff. So so it's just it's a great learning thing that Amanda has me on a journey of learning, and this has been really great, so thank you.
I also wanted to kind of agree with that as well. Like, I think Amanda started me on this journey in like 2019 fall, and that's when I first started learning about intuitive eating. And just as providers, like it just goes very much against, I feel like, so much of what we learned in medical school and residency or in our training. And so I've had to do a lot of unlearning, and there's a lot of cognitive dissonance at the beginning. But similar to Anuj, when I did my integrated fellowship, and actually it started with me reading Roxane Gay's memoir. Like, I have thin privilege, you know, my whole life. And so this is not something that I really knew about. And then I read her memoir in 2017, and it really opened up my eyes in terms of weight stigma and the impact that has on people, and just in our medical field. And so, Dave Friedman started this, talking about trauma in the beginning. And I think, I think often about like, what is the harm in not acknowledging and not recognizing the stress response and trauma and how that impacts so many things, and instead sort of focusing on that. And so I think it's a journey. Like if anyone else is having like, oh my God, like cognitive dissonance, I would just say like, have compassion for yourself, because it's definitely a lot of unlearning and yeah, and shout out to our intuitive eating group every Tuesday. Amanda and I co-run together. Thanks, Amanda. That was fire. And I agree, TED Talk, we're setting you up for that.
Yes.
No, yeah, and I really appreciate you all staying on. Honestly, there's more people on here than I expected to stay on so many minutes later than 9:30. So I think that's really, really great. And I'm happy to continue these conversations, for anybody that's interested, because I think there's a lot, like we at Heartland are so open. I think we're just more than I've ever seen in any other medical center. I think more open to just, learning and kind of changing and being more affirming. And so I really love that about Heartland, and I love that about you all. And so, I'm really excited for where we can maybe take our medical care.
All right. Well, thanks so much. Yeah, if you can share those slides with the group, I think that would be really helpful.
Yes.
You're going to have to copyright those, it sounds like. But thanks to everyone for joining in today. And if there's any additional questions or anything, let us know, and have a great rest of your day. Thanks.
Thanks, everybody.
Thank you.